Good afternoon, everybody. Welcome to this meeting of the Health and Wellbeing Board. I am Councillor Jo Coles. I'm the Executive Member for Health, Wellbeing and Adult Social Care. Thank you to those who are attending. We have two remote participants. The substitute, Mabs Hussain, who is a substitute for Lisa Winwood, the Chief Constable, who will be attending remotely, and Zoe Campbell from TUVE is also attending remotely because of transport problems. Just to make the meeting aware, that means that if we were making any formal decisions, they wouldn't be able to take part in that, but they are welcome to take part in the discussions, and someone is going to tell me if they want to interject on any of the items that we're talking about this evening. First of all, any other apologies? Yes, I've got apologies from Simon Morritt, who is substituted by Lucy Brown. Welcome, Lucy. Apologies from Nigel Eyre. Apologies from Sian Balsam from Health Watch, who is substituted by Emily Dowse, who was also welcome, Emily. Apologies from Jamila Hussain, who is substituted by Michael Melvin. Thank you, Michael. Apologies from Sean Jones, and I've talked about the other two. Great. The first item on the agenda is declarations of interest. Does anyone have any interest that they need to declare at the start of the meeting? No? Great. And then agenda item 2 is the minutes of the meetings that we held in July and September, because we were unable to ratify the minutes in September because of a scheduling problem. So I will authorise those minutes now. We've had 2 amendments to the meeting, which I'm happy to accept. Does anyone want me to clarify what those 2 small corrections to the minutes were? There was one around Michelle Carrington's job title, and one item 158, paragraph 3, rather than saying it was brought, it's changed it was brought about. So it's, and then a commissioned service clarified on page 158 as well. So we'll accept those minutes, and I'll sign those minutes with those 2 amendments made. Thank you. And then moving on to item 3 on the agenda, which is public participation. We have 9 public participants. I think 1 is attending remotely. Yep, and we'll go through those in order. And the first of them, where have I got my list? Yeah, just had it. I did just have it. Payson Muller is the first public participant. If you'd like to come up to the table, is Payson here? He's running late, in which case we'll hear Payson last, if that's okay, and we'll listen to the Alec Freya, who is our remote participant. We'll listen to Alec first. Alec, can you hear us okay? Can you do the time?
Hi, can you hear me?
Yes, we can, Alec. If you're okay, you've got 3 minutes to address the meeting. And would you like me to tell you when you've got 30 seconds left?
I think I'll be in good time, but yes, if you would.
Okay, thank you. The floor is yours.
Okay, I'm Alec Frere, lived in York 25 years, kids go to school here, kids did go to school here, kids work here. I'm also Alec Frere with 3 master's accreditations in social work, the commissioning of public services, and the procurement of public services. What I'd like to ask very simply is if the chair and the board would give consideration to inviting the Director of Public Health to organise a time-limited working group to bottom out the diagnostic protocols that apply to ADHD, autism, and dissociative conditions. It's a bit of a mouthful, and the best illustration I can give of what this means is that if you could imagine the fairy tale of the princess and the pea, well, the P in medical terms is anxiety and depression, and the diagnostic layers that are put on, which are the mattresses, are the subsequent difficulties around the nuanced differences between ADHD, autism, and then dissociative conditions. And I think that the the fairy tale kind of, in that sense, encapsulates the problems that everybody faces, both patients, doctors, and those providing services. I have looked at a number of documents since maybe March this year through Freedom of Information Act requests, and as a former commissioner and a former subject matter expert in procurement for this sector, I've kind of been scratching my head thinking, how have they done that? And it does seem that the pressure of time, the volume of work, the differences between what would be a strict medical view in terms of everybody who presents at a GP surgery with these conditions is likely to have some sort of anxiety and depression. So the diagnostic protocol. Sorry? You've
got 30 seconds.
God, that's technical. The request is that the board and the chair give consideration to inviting the Director of Public Health to initiate a public health information campaign on these matters. End.
Thank you. Thank you, Alec. Thank you for your contribution, which we'll consider during the course of the meeting as those agenda items are discussed. But thank you for your contribution. Can I ask Hilary Conroy, who is going to also speak in the meeting, I think on agenda item 4, the Autism ADHD Assessment Pilot. Hilary, do you need me to give you a 30-second warning? Lovely. The floor is yours.
I'm here representing York Disability Rights Forum, and I work on challenging the autism and ADHD pilot pathway. We've written 2 long legal letters setting out the various ways this pilot is unlawful, breaching the NHS constitution, NICE guidelines, data protection processes, and much more. The responses from the ICB have been poor, both in consideration and in quality. The ICB's most recent response bizarrely states, the service provision for ADHD and autism assessment remains as it was before the pilot commenced. The intention has not been that those who use the Do It profiler be removed from the waiting list. However, some may choose not to remain on the waiting list once they have completed the tool. This does not amount to a change of commission service, as the offer to patients remains the same. We say any list of people who completed the Do It profiler but did not meet the criteria is a list of people who cannot access assessment. This is not a waiting list. These people receive poor quality general advice from the Do It profiler and then remain on a list for no known purpose. Anyone who does not meet the pilot criteria will not be able to access assessment or diagnosis unless or until the ICB's commissioning arrangements are amended. The ICB has said that there is an internal group meeting weekly to discuss the pilot, complaints, freedom of information requests, and more. It is clear from our most recent FOI reply that the ICB is spending more time and resources figuring out how to withhold information from the public than they did in considering this pilot scheme. I wonder how much better these significant resources might be used to provide support to neurodivergent people instead. Let me share some blunt numbers. The retreat completed a total of 295 assessments for autism and ADHD in the 22-23 financial year. On the 13th of June 2023, there were 1,700 people waiting for assessment. There were 2,396 people waiting to be triaged. If we take about 300 assessments a year as business as usual, then the waiting list for assessment will take over 5 years, and the waiting list for triage will take about 8 years. Where does that then leave the 2,753 people on the third list, those who did not meet the criteria? They present an extra 9 years of waiting list if the provision remains unchanged. So if we are to believe that all 3 lists are one waiting list, it will take 22 years to clear it. The Vale of York CCG website states, under the pilot approach, no one will be denied an assessment. But how can this possibly be true? The dictionary definition of a waiting list is a list of people who have asked for something that is not immediately available, but will be in the future. I must remind everyone here that this pilot scheme came about because there is not enough time left in the retreat's contract to meet this demand. This has not, and by all accounts, will not be changed. To suggest that at some point in the future, 2,700 plus people might be assessed if they just hang on in there is unethical, unfair, and untrue. Thank you.
Thank you, Hilary, and your comments will be taken into consideration on the agenda today, and thank you for keeping to time. The next speaker is Stephanie Brodie. Stephanie has just spoken to me to say that she is very nervous, and because she is neurodiverse, if she does say anything untoward during the course of her contribution, just to anyone who might be listening or watching this back, apologies in advance if you hear anything that you wouldn't normally expect to hear in this meeting. But Stephanie, you're very welcome. You've got 3 minutes. I will give you a 30-second warning when you've got 30 seconds to go. Take a deep breath. It's all going to be fine. And the floor is yours.
Told me. Imagine waking up one morning feeling very heavy in the head, crying, and sitting on the top of your stairs and wanting to throw yourself down it and break your neck. That was me on the 11th of October. I later that morning tried to commit suicide. Before that point, I'd gone through 3 different doctors and trying to get help and support for my autism and ADHD. I'm actually in the middle of an autism burnout, which is not mental health, and that's the problem here. I have been for an assessment at mental health. I have referred myself to talking therapies, all of which I do not fit the criteria. When I arrived at A&E, apparently I'd been out for 10 hours. I ended up leaving because I didn't feel safe. I was sat on a spinning chair, which part of autism, I'm highly sensitive to noises, movement, which made me feel even more unsafe. And I left, apparently of my own accord. I wouldn't have thought so because I couldn't walk very well from the York Hospital to Pottery Lane. That evening, my partner I was dating left me. So I didn't want to commit suicide, but I don't feel I have any hope, not in this city, because I've been misdiagnosed so many times with personality disorder and borderline personality disorder. And it continues in this city to be that. It is incorrect. And the reason it's incorrect is because the Maudsley Hospital has done an in-depth questionnaire or whatever on me, looked at the criteria, and the particular Professor Asherson, he specialises in BPD, autism and ADHD. The problem we have is we don't have the proper training for NHS staff, doctors, because the assumption, they look at something like emotionally dysregulation, and yes, that's dominantly a BPD thing. It's also part of autism and ADHD. And the reason that happens for autism and ADHD is due to executive functioning and the sensory overload and meltdowns, which means self-control goes, start to swear, working memory, can't go to the toilet, can't eat, can't work. I don't have any children. I've never been married. I'm 49, 50 next year. And when I went to my first assessment at Huntington House, I was told that they would try and help. At the end, they couldn't. And until I was stable, whatever that means, to ring crisis or 999 if I try again. That is what is happening. So I am isolating myself at home. I'm trying to work hard with adult social services, direct payments, but unfortunately I can't use my direct payments because I can't have the PAs that I need because the money is got to be £13 when really it should be £20. So every which way I'm knocking on doors for help and I'm getting nowhere.
Thank you, Stephanie, and thank you for your contribution, which we will consider when we reach those relevant items on the agenda. Hazel Kerrison is our next speaker, who's also speaking on item 4. Hazel, I think you know what you're doing because you've done this before. No, definitely not. Would you prefer me not to give you a warning when there's 30 seconds left? Okay, I will just tell you when your time is up, but the floor is yours and you're very welcome. Thanks, Hazel.
Since I last spoke at one of these meetings, criteria 1 of the autism and ADHD pilot has been changed to no longer require a crisis plan to be in place. However, the new criteria does require a direct referral from the community mental health team, and this in itself has its own issues I would like to outline here. It has been well documented that mental health services are often not the best environment for autistic and ADHD individuals. There's often a lack of understanding within these teams. Many of the usual go-to treatments and therapies have been shown to be ineffective and even damaging for autistic and ADHD people. And in short, this two criteria is forcing people to engage with a service that was not designed for them and also lacks the resources to support them. Many aspects of both autism and ADHD can be easily misinterpreted as non-engagement, combativeness, and in some cases be misdiagnosed as mental illness. The National Autistic Society has heard countless stories of autistic individuals getting trapped within this system, being hospitalised for years, over-medicated, restrained and gaslit, all while being forced into an environment that both bombards them with potentially painful sensory input and neither meets nor understands their needs. I'm sure that we've all read the inquest of deaths of people such as Zoe Zambara, but autistic individuals failed by the system, this same system that the pilot is now forcing vulnerable people to engage with. Because as much as we may not want to accept it, we are talking about a very vulnerable group of people here. I'm sure we've all seen the statistics about neurodivergence and addiction, eating disorders, self-harm and suicide. These have been highlighted in the suicide prevention strategy published in September. This report states clearly, undiagnosed or late diagnosed autism may be a preventable risk factor for suicide. Therefore, early identification and timely access to autism assessment services is vital. Many behaviours consistent with undiagnosed ADHD are also highlighted in reports such as substance misuse, social isolation, and economic adversary. I myself have been diagnosed with schizoaffective disorder, but I'm also autistic and ADHD. I have a long history of eating disorders, self-harm, suicidal ideation, substance misuse in the form of self-medicating. As such, I have over 17 years worth of experience within the mental health service. I've seen myself how my thoughts and behaviours have been misunderstood, how I've been blamed when inappropriate treatments have failed to work. It was not until my autism and ADHD were identified that I was finally able to not only understand myself and advocate for myself, but also gain the correct support. Because that's what this comes down to. Without correct assessment, correct diagnosis, and a full picture of what's going on for the individual, it is impossible from both the individual and the professional side to be able to put the correct support in place. This pilot is not only harming our community, forcing people to engage with incorrect services and causing much public confusion, but it's also putting pressure onto an already overwhelmed mental health service, a service that was never designed to work with us and lacks the resources to take on this new responsibility.
Well done. You had a whole 5 seconds left there, Hazel. Thank you very much for your contribution, which will be taken into account when we reach that item on the agenda. I would next like to invite Councillor Jason Rose to have his say in the meeting. Jason, you have 3 minutes and you know what you're doing with the mic.
Thank you. Good afternoon, everyone. Noting the request for updates on the autism and ADHD pathway, I wanted to come and express my concern around issues with the pilot and ask for some increased confidence in concern, understanding and next steps. Recent changes don't look to me like improvements. I'm concerned that acknowledgements of issues to date have mostly been talking about communications and not resolving the other issues. Even on comms, the ICB website today doesn't explain the process or criteria, but I think it's fairly easy to explain. If you're graded red from CMHT or by GP referral and meeting one of two incredibly unlikely scenarios, the retreat handles things. The Guardian says it's a 12 to 15 month wait for triage, followed by the retreat 2.5-year waiting list. If you don't meet those criteria but have a GP referral, you're asked if you want to join an ICB waiting list that currently leads nowhere. That's effectively 4 years of waiting in an emergency scenario, eternal waiting for a non-emergency scenario. For thousands of residents in York, that sounds entirely hopeless. It doesn't mean a multi-year wait list, it means an eternal wait pit. Imagine I'm injured, I lose the ability to walk, but I'm told it isn't life-threatening, so I either deal with it on my own or I can loiter and hope I get seen in the next few years. I don't think that's acceptable. I don't think this pilot as it stands should have really been possible, because I personally expect the ICB to know more and care more and be more capable than I've seen from this. Pilots that don't succeed get cancelled, or they're not really pilots at all. But here I am concerned that key problems haven't really been addressed. And since the Health Watch report, these criteria have been tightened further, and I haven't seen work myself taken to address the condescending language that was called out in feedback, or the fact that over 80% of people never shared their report with anyone. There's now famously YDRF legal action, but to me the response doesn't appear to be owning the overarching mistakes and problems. NHS England published advice this year. For an undiagnosed autistic person, healthcare, education, statutory protection and benefits may be withheld, and restricting diagnosis can lead to multiple forms of abuse, poorer mental health, suicidality or hospital admission. Most importantly, they say it is important that ICBs do not restrict or withhold access to an autism diagnosis. And the Autism Act 2009 also calls out things we must do, but aren't sufficiently doing, in my opinion. The most recent autism strategy for York said the waiting time should be 3 months. It's now 4 years for some, infinity for the majority of those in need. I think it's important to say that prioritising those in greatest need is good. That doesn't mean ignoring everyone else. So please address those issues that have been present since day one and are still present, not just the comms. The undeniable capacity challenges and the financial limitations are caused by a government that, in my opinion, frankly doesn't care. But here in York, we should and we could be much better, even within our limited means. Thank you.
Great, thank you, Councillor Rose. And your comments will be taken into consideration on the agenda as we go through the meeting. The next public participant is Councillor Burton. You have 3 minutes, Councillor Burton, to address the meeting, and we will take your comments into consideration too. Do you want me to give you a 30-second warning?
Yeah.
I will. The floor is yours, Ben.
Great. Hi there. Yeah, since the first lockdown, I've become a carer for my partner who's struggling with depression, anxiety linked to CPTSD. She's also become alcohol dependent and recently had bouts of psychosis. I wanted to come here to share our experience of mental health services in York, as well as feedback from conversations with other services and residents. As you'll all be aware, mental health crisis provision is really bad. This was outlined well by the recent Health Watch report and the academic paper Death by 1,000 Cuts. In June, my partner made an attempt on her own life by entering the river. She was rescued by police and taken to A&E. Upon being discharged 6 hours later, she received no follow-up from mental health services. In July, she started having episodes of psychosis, which presented a risk to my life so severe that it resulted in arrests and police being assessing it as the highest possible level of risk. In spite of this, she only received 6 assessment sessions from TUV and was discharged while the issues persisted. During this time, she was extremely suicidal, but that risk was completely ignored, leaving me to have to go against police safeguarding advice and return to the property so that I could care for her and make sure that nothing happened. Other service users and carers in York, during that period, my partner reached out to mental health crisis teams regularly. Not only was she not provided any support, she was met with comments whilst explaining her suicidal ideation, such as, maybe you should, what do you expect me to do about that? And if you really wanted to, we can't do anything to stop you. Other service users and carers in York talk consistently about a trauma of interacting with the crisis team. The paramedic told us that mental health calls were the worst to attend because they knew nothing was going to happen after they dropped them off. This sentiment's been echoed by the police, who face the sharp end of the stick of people who've been left in crisis. There's a few key areas which need imminent work, which I wanted to raise quickly. Number one, the culture originally highlighted in Death by 1,000 Cuts of undermining the experience of severely traumatised people and treating suicide as an acceptable risk in the city. Number two, a lack of transparency. Statutory and charitable services tell me of not having any direct communication or relationship with TUV staff. That mirrors the experience of service users and carers too. There needs to be a concerted effort to break down barriers of communication between services in the city. Number three, approach towards dual diagnosis. There's no national policy to support TUV's approach of withholding treatment for people in active addiction.
Got 30 seconds, Councillor Byrne.
And mental health is a key driver of substance misuse and needs to be tackled jointly. Number four, linked to the above, the complete lack of emergency detox facilities in York, which is used as an excuse to not to inpatient people in mental health crisis at Foss Park. My partner will have waited 5 months for a detox bed when she was first told she needed one. This has a knock-on effect on the police too, who won't section people in addiction because of fear of backlash from TUV staff when they call up Foss Park about using their sectioning powers. And number five, a general introduction of trauma-informed training for all staff, including council staff, mental health, police, just broadly across the way.
That's your time, sorry.
Yeah, I know that's the end, so thanks for everyone's time and happy to discuss anything with people who wish to in future.
Thank you so much, Councillor Burton, and for sharing your lived experience so publicly. We will take those comments into consideration on the agenda. Can I next ask James Cannon to come to address the meeting, who would like to speak to us on agenda item 6, issues relating to older people and health. Jim, the floor is yours. You know how to use the mic? Been here before? Yeah. I'll give you a 30-second warning when your time.
Seem to have turned it on and off. Good evening. My name is Jim Cannon and I chair York Older People's Assembly, and I also chair the Age Friendly York Citizens Group. Both organisations aim to involve older people in the government of the city and in having a say in services. In the case of the health service, this is very challenging. The reorganisation leading to the Humber and North Yorkshire Integrated Care Service is now 18 months old. Engagement of the public was heralded as a major virtue. This has been one of the biggest failures ever, in my opinion. I would guess that if you went out and did a survey of the citizens of York, let alone the country, more than 90% of the population wouldn't have a clue what most of the many acronyms mean or what difference, if any, has resulted from the reorganisation. YOPA members were hopeful that the local York Health and Care Partnership would open up new avenues of communication and involvement. Sadly, this has not happened. Meetings are held behind closed doors and summary minutes are published by this Health and Wellbeing Board. The report on agenda item 6 is full of general phrases and statements and few specifics. I wanted to set out some thoughts on one particular issue, and that is on page 48, it refers to the winter resilience plan. It says the plan is being finalised and will be shared across partners when complete. What about the public? What involvement has the public had with any of the planning for winter resilience? The reports give a lot of great statements and few specifics, few facts. It doesn't give ordinary members of the public confidence that there will be an improvement in the service delivered to them. I note as well in the chair's report earlier on in section 5, there is a particular reference to the vaccination programme in care homes and that there has been a low take-up on flu and COVID vaccinations. I find it amazing as an ordinary citizen that we are expected and do go and get our flu jabs and COVID jabs, and yet the people who are caring for very vulnerable people in very specific circumstances aren't involved. I'd like to leave you in the last 30 seconds with 3 comments. Number 1, when will the health and care partnership meetings be open for public attendance? I find it appalling that they haven't been so far. If you go to other places, they have. Number 2, how will you involve and consult and advise the general public about the revised, finalised winter plan,
You're out of time,
given
I'm
it's
afraid.
next week? And number 3, what actions will be taken to improve communications with the public? Thank you. Sorry I went over.
Thank you. Thank you, Jim, and thank you for your contribution, which will be taken into consideration when we reach those items on the agenda. Could I ask our next contributor, Carla Morris, if she'd like to come forward? Is Carla here? Oh, is she? Okay, in which case, huge apologies to Carla if she wasn't. I don't think we knew that she was attending remotely. So huge apologies. If you'd like to pass back to Carla our apologies for the missing her off the agenda, she is very welcome to participate in a future meeting, or she's welcome to send something in writing that we can circulate to the board members. Finally, then, can I ask, I think Payson Muller has arrived. Payson, hi, you're very welcome. If you'd like to come forward to the table, you just have to press the microphone button to make it work. You have 3 minutes. I'll give you a 30-second warning when you've got 30 seconds left. Of course.
Oh, thank you. Yeah, 1 minute warning, please. I'm just going to set a timer on myself for the 2 minutes. So I want to make 3 points. They are, I want to tell you about me and my family very quick, and about the statistics as I understand them and that I'm concerned, and about the diagnostic protocol. Point 1, my family and I are personally impacted. It's taken years to get help. Point 2, the population need of ND people has been woefully misunderstood. For me, the statistic of 5% increase, 500% increase in the call for assessment was in the agenda. And I would just like to focus on a much more important to me issue, because I have daughters, ND family, and an ND wife, is that women and in general have been misdiagnosed and gone under the radar, as my wife has for many years, if they had the lottery of being lucky to be able to mask and get by in the world. But that doesn't mean that they don't have to work really hard to do it. And it doesn't guarantee that my kids will follow my wife's example. The important thing is that women have only been acknowledged in the last handful of years to have ADHD and ASD, and both of them together. So I'm the amateur here, but I expect the public authorities to know this, and it seems that you don't. While we're talking about things that we don't really know about, I would like to say that the diagnostic theory pertaining to ADHD, autism, dissociative conditions is, in my experience, also equally misunderstood. For example, I'm 50 plus years old. I struggled all my life with my wife's help. She's, exhausted herself. And now I have kids to worry about how they're going to perform in school. Okay, I would like to finish now, and I would like to ask if it's okay that we spend the rest of my 3rd minute here in reflective silence to contemplate the families of those who've lost loved ones to suicide or have died while being detained in a mental health factor, while being hospitalized for being neurodiverse and not mentally ill. So if we could spend the rest of our time on reflection, I would appreciate it.
Thank you. And thank you, Payson, for your contribution, which will be taken into consideration, as the others will, during the course of the meeting. That draws us to the end of our public participation. Thank you to everybody for taking part and for, in the main, keeping to the time. I'll move on quickly to the next item on the agenda, which is agenda item 4, which is the report of the Chair of the Health and Wellbeing Board, which is on page 19 to 29 of your pack. I would assume that everyone who is in the meeting has had a chance to read the report. I would draw people's attention to the responses to the Health Watch report around mental health services in York, which is on page 21, and the Better Care Fund update is also worthy of note, which is in the appendix in Annex B. And finally, I wanted to draw people's attention to particularly the focus on early intervention and immediate care and reablement that Better Care Fund is being used for. But the other point in the part of the report is the actions from the previous Health Watch report, which, if any partners who are present are able to update us on, they're on page 29, Annex C of the Chair's report. So if anyone has any updates that they're wanting to share, if they could indicate, or if they've got any questions or comments that they want to make on the report. Yeah.
Thank you, Chair. So this might be a good opportunity just to respond to some of the comments. That's what I'm wondering, Chair, given that we've got Annex C set out there, which we at the last meeting we did have the Health Watch report. So I gave a response as we were at that point. What I thought might be helpful is just to give an update in terms of where we were. So I suppose what I wanted just to confirm following the Health and Wellbeing Board on the 20th of September is that the referral pathway is now online. There is information about the approach that we're taking and why. There is a frequently asked questions section as well. The engagement plan is set out on the website, and the details of the upcoming engagement are also set out in detail. In terms of our upcoming engagement, there is a face-to-face event at the York Community Stadium on the 12th of December, taking place from 1 till 4 p.m. There is also a virtual engagement session taking place on the 14th of December. That's 6 to 8 p.m. In terms of the engagement plan, we're in a live pilot, so it's about using this opportunity to listen to people. We've heard speakers at the previous meeting in September. We've heard from 7 people today, all of which is being captured. I want to reassure you that everything that's been heard has been captured today and has been fed back through the project team and will be fed through to help to further shape the questions and the focus groups that we have arranged for the 12th and the 14th of December. There'll also be the healthcare professionals will be there, certainly for the face-to-face event. The reason that is 4 hours is because there is the opportunity to just have those conversations. I think some of the points that have been raised today, so for example, Hilary Brodie around some of the aspects of the waiting list, and some of the ways that the waiting list works and the mechanisms around the Do It profiler, not to tell people how it works, but to hear how it could work and how we can improve that. So that's the intention of the engagement, but also to talk genuinely with people with lived experience and with providers of services around how we can better support people whilst they wait, recognising that the wait is in years and not months, sadly. I do take the point of what was said earlier about it feeling like an eternal wait, and I want to know that I have taken that on board in terms of how that feels. So thank you for sharing that. So the engagement is about recognising that we know we don't have the solutions right now. I want to share that the ICB did meet with the National Health Minister yesterday to share some of our concerns locally and potentially some support around how we can be a better supporting neurodiverse environment and society. I think some of the things that have been brought up today around point to a stronger social model. It's not about creating a medical model. So that these are some of the things that we have raised and that we did indeed raise with the National Mental Health Minister yesterday. Other examples for around disability support allowance, for example, which I know was raised last time by one of the members of the public. That was one of the points that we did raise. So when we talk about social model and we talk about more support in terms of that concept so for example with York, we've been a neurodiverse city and accepting and working with educators and employers as well in terms of the support and the role. However, that is a long-term aim and much broader than health. We also recognise our responsibility, particularly to explore how we can better support people whilst waiting, but also be maximising the capacity that we do have. I think it was mentioned earlier about the size of the waiting list. So, for example, ensuring that people do have access to specialist triage as soon as possible in order to have access then to, for example, reasonable adjustments with employers, with educators, if that is proving to be a barrier. So we are in that live pilot stage in terms of continually listening and changing. There are a number of comments that probably will merit a question and answer response on our website. So I would like to offer that and to confirm that we will do that. So, for example, around the criteria, I'd like to be able to pick that up, and we will publish that response on our website. Certainly, what I'm picking up is an interpretation that the criteria have been tightened rather than broadened. That's certainly not my understanding. So I need to go back and clarify that in terms of actually that the criteria have been broadened and not tightened. So, for example, that's a point that I'd like to take the opportunity to leave today and take back and publish on our question and answer section of the website. Thank you, Chair.
Thank you, Sarah. Does anyone else want to come in at this point? I've just got a couple of, no one's indicated up there. I just had a couple of things that I wanted to pick up. One was just, I just think there is something around the scale of public participation we have seen in these meetings. I think over the last, is it all of the meetings that I've chaired? I don't know whether Councillor Runsman, in your history of chairing these meetings previously, I'm gonna go out on a limb and say it's not down to my changing style of chairing these meetings. I'm gonna say it's probably down to the things that are on the agenda, and therefore, you know, I do think it is noteworthy that there has been a real sense of public participation on this particular item, and that concerns me as an elected member. And I think that points, no one is underestimating the scale of the challenge that you're facing and that we are facing as a city. But equally, I think the picture that is being painted is of a lot of pain in the community that, this pathway and the profile, or whatever we're going to call it, needs to be able to address. And that does concern me, and ensuring that we have plans in place to reassure people on some of those points, I think, is really important. The other point that struck me was around changing circumstances and what people need to do if their circumstances change, either because they have a deterioration because of a lack of diagnosis, or just because of other things that might be going on in their lives, and just ensuring that we have a kind of a open door, for want of a better word, to be receptive to those kind of things. I think was also something I took from the comments that we've heard today. If no one else, however, wants to come in at this point, Councillor Runciman, did you want to come in?
Yeah, just briefly, Chair. I don't think it's you. I think it's the importance of the subject, and it is a very important subject. But I still have a concern about everything being done online. People may not have access to online forms to fill in. They may not feel able to put things into the format that is asked for by those forms. And I think that has been my worry all the way through with this. It's assuming that everybody has the right equipment and the right signal and even access to electricity when they may not. And I think we have to take that into account and allow for it.
Thank you. Yeah, I think that's a very valid point. Does anyone else have any comments they wish to make at this stage? Otherwise, I'm going to move on the agenda onto agenda item 5, which is the Health and Wellbeing Board Terms of Reference, which Sharon Stoltz, the Director of Public Health, is going to speak to. Thank you, Sharon.
Thank you, Chair. I'm not going to go through the terms of reference in any detail. I'll assume that board members have had an opportunity to read them. Just a couple of points I'd like to bring to the board's attention. The terms of reference, we've tried to incorporate some of the discussion that's taken place at previous board meetings around revising the membership to reflect the wider focus of our joint health and wellbeing strategy. So there are changes around membership is a suggestion that we have representatives from housing, for example, and also that we invite the fire service to participate in the board as well. So the terms of reference reflect that change. Just then highlighting some of the points on page 32 in your pack. It's proposed, and this was discussed at the July meeting of the Health and Wellbeing Board, that the mental health partnership is realigned so that it is aligned to the York and Health Care Partnership. So the ICB Place committee of the ICB, rather than this group that has been widely discussed, Chair, and it seems to be a unanimous view that would be a positive move. That the Population Health Hub continues to be responsible for the production of the Joint Strategic Needs Assessment, and continues to update this board on progress. So that links to item 9 on the agenda today. The proposal then is that we move away from having standing subgroups, but that instead we commission task and finish groups to deliver any pieces of work that the board has commissioned, and that some of the other groups that partnership groups that have previously reported here, such as the Ageing Well Partnership, for example, continues to have a relationship to the board. They can still bring agenda items to the board, but that they're not formally established in our government governance arrangements. The only other point to bring to the board's attention is the governance process, because the Health and Wellbeing Board is a subcommittee of the council. It is subject to the council's governance processes around the council constitution and the terms of reference needing to be approved by full council. So on that basis, I would like to bring members' attention to paragraph 19. So today, the Health and Wellbeing Board can agree the terms of reference in principle, but they won't actually be endorsed until they've been discussed by the Council Constitution Working Group, and will be ratified at a full council meeting, which will probably take place in March. But the recommendations then on page 34 that the Health and Wellbeing Board are asked to approve the terms of reference in principle, that following this meeting, we refer them to the Constitution Working Group, and then for the monitoring officer in the council to ensure that any revisions that the council's constitution group requires are taken forward to full council at the March meeting. So happy to take any comments or questions, Chair.
Brilliant, thank you, Sharon. And my understanding is this is kind of as you say, the start of a process of revising the terms and conditions. Does anyone have any comments or thoughts, Councillor Runciman?
Thank you, Chair. This is an exercise we've carried out at various intervals during the life of the Health and Wellbeing Board. I think the idea of working groups, subgroups is a good one. We've had that sort of thing before, and it's worked extremely well. They don't necessarily need to be part of the construction of committees of the council, and that needs sorting, because you get a lot more out of working groups if they're done informally and private than you do if it's a structured meeting with an agenda and a chair and everything else that's required. The other thing I'd like to mention is it's important to be able to bring people to the board that you want to give you a particular report. And I notice you've got the Chief Fire Officer as a TBC. We've had lots of discussions about having the Chief Fire Officer, and they do some very important and valuable work in the area of health. And if the ultimate decision is not to have him here, you can also bring him in when you have a report to give or you have some questions to ask. And I'm sure that can be borne in mind. Thank you, Chair.
Thank you. That's incredibly helpful. Alison?
Can you just clarify about the mental health partnership, whether that's going to report into this Health and Wellbeing Board or has it been left?
So the proposal for the mental health partnership is that the reporting relationship in governance terms will be to the York Health and Care Partnership. But of course, this board is very interested in mental health issues. So I'm sure we would still be willing to receive agenda items that are relevant for the board. We would still want to see any strategies they produce, for example. But I think the regular updates could be through Sarah's updates to the board as NHS Place Director. But I think we would want to give an open invitation to the independent chairs to place items on this agenda and bring anything to the board's attention.
Thank you. I'll just add to that. I'll come to you one second. I actually spoke to the Children's Safeguarding Chair this morning and had exactly that conversation with them about potentially them coming to meetings when there were particular items relating to children on the agenda. And I guess the same would apply to adult safeguarding. So I think that was already kind of on my radar to do. But I think if we can do that perhaps more formally in terms of the planning of the meetings. Michael.
Thank you, Chair. Just to say, I very much welcome the recommendation to have someone from Economy and Place at Health and Wellbeing Board, given the impact which issues around economy, the environment, jobs, those kinds of things have, for better or worse, on the health and wellbeing of our population. So I think that's really, really helpful. I think, you know, potentially there's a greater agility in the board to have task and finish groups rather than a set number of groups which continually report. I think with regards to the mental health, I think given how important that is on the agenda, it is it may well be the right place in terms of the reporting into the local health and care partnership, but certainly I would imagine that this board here is very, very interested in the work which goes on around mental health and wants to continue to receive information and updates around that.
Thank you. That's yeah, very helpful. Did anyone else want to come in on the terms of reference and kind of programs moving forward? Just Zoe Campbell from Tube is indicating, so we'll just hear her remotely.
Thank you, Chair. And I suppose some of what I'm about to say here also goes back to the previous agenda items. So my apologies for my IT clumsiness in that I didn't get a hand up earlier on Zoom to show that I wanted to speak. So absolutely totally committed to mental health contributing to the public health agenda. We welcome conversations about how TUV as a provider could potentially provide more information and support all of the work in public health that needs to be done. Some of the things that we've been talking about was response to a previous Health Watch report as well into mental health services across York. And there have been a set of actions that have been presented to this board at a previous point. So I won't go into those in a lot of detail But I suppose some of the things that I would like to pull out is that we have established jointly across the whole system, because this is not just a TUV as a provider issue, it is also a broader system issue, including all of our colleagues in other statutory services and also voluntary sector. There is a board that's been established around the hub in York to improve the services there, to address any issues that we've been facing, and also to look at how we can roll that out. And I think just in terms of that, some of the things we've been talking about that focus on crisis, I mean, prevention is key, and we really need to as a health and wellbeing board and as a whole system, to focus a lot on prevention. And I suppose one of the things that I would say is that we've seen some really positive work where we've had roles working into primary care, where there's the reducing conversion rates to secondary care in mental health down to 3%, which is excellent, and something that as a whole system, I think we absolutely need to focus on. There is work going on as a system. Again, this, as I say, it isn't just about one provider organisation, but as a system, we are looking at our kind of urgent care pathway for mental health. So across the whole system, what does that look like? How can we make improvements? How do we make sure that people are accessing the right services at the right time? I did also just want to pick up on conversations that I personally and my teams have been having with Yorkshire Ambulance Service and the police, to make sure that we are working holistically, and just touching upon some of the points that were made earlier about potential perceptions and feelings from other statutory organisations about services that are provided for people in mental health crisis. We're actively doing something to address that, and to make sure that we can put solutions in place where we all work more actively together. And just picking up slightly on the drug and alcohol piece, as an organisation, as a mental health trust provider, TUV does provide support for people who have co-diagnosis around drug and alcohol dependency and mental health issues. And that's, I'm not saying that we're absolutely perfect in that, but it is something that we do. And again, welcome a system conversation around where things aren't working very well, what we can do as a whole system, and in terms of public health, because these are public health matters as well, what we can do to improve those. Thank you, Chair.
Thank you, Zoe. Can I just clarify that those last points were they addressing the Chair's report? They weren't about the terms of reference?
They were addressing the Chair's report. And again, apologies, Chair, that I fumbled and I did not alert you to the fact that I wanted to come back on agenda item 4 at an appropriate time. So I'm trying to cover both off there. I hope that's okay for the minutes of the meeting.
That's fine. As long as we've clarified. I'm sure there's some cutting and pasting going on. Great. Does anyone else want to come in on that item? In which case, I think we need to officially need to do page 34. We officially need to approve the proposed terms of reference, which means that this now moves forward into the Constitution Working Group and will then move into full council. So it's still, if people have thoughts and burning issues that they think need to be either included or removed, then there is still plenty of time to do that. To Tracy, if you have them. Great. Thank you. And thank you to officers and the public health team for their work in pulling these together, because it is hugely appreciated. Thank you. I'm just wondering whether anyone would like to take a very short break if we're an hour in and we're actually on time. Is there a mood to stop for 5 minutes, or are we happy to plough on? Plough on. All right, I'm happy to plough on. All right, fine. We might actually therefore not. Oh, sorry, we were approving those terms of, yes. I didn't hear anyone say that they weren't. In which case we'll move straight on to agenda item 6, which is the report from the York Health and Care Partnership. Sarah, I think you're going to speak to the report, and then we'll have a discussion. Thank you.
Thank you, Chair. Okay, so yeah, thank you. In terms of the agenda items, so we've had two health and care partnership meetings since the last Health and Wellbeing Board meeting. So you can see the minutes of both sets of meetings are in the pack. So I'll just give a sort of brief overview and highlights really, if that's okay, Chair, and happy to pick up any questions. I do have a video to show. So what might be well, what I'm wondering is I might do my spiel, and then we can either come to the video at the end of my spiel and then questions and discussion, or we could do questions and discussion after the paper and then do the video at the end. I don't know if you've got any preference.
Why don't we end on the video?
Sorry?
Well, why don't we end on the video?
End on the video. So questions and discussion on the paper, and then we'll do the video. Okay, sounds good. So in terms of the September meeting, now the winter resilience plan, I know there's a comment earlier about the winter resilience plan as well. So the plan actually came to this meeting before it came to the place board. So the meetings were slightly sort of back to front. So that was the September Health and Wellbeing Board meeting. In terms of the plan, just for a point of clarity, what the plan was in essence was, and of course it's one of those kind of misnomers really, that the health and care system is entirely joined up and we all know exactly what is on offer. And of course it absolutely should be, but there are so many services and there's so many complexities across prevention services, adult social care, health services, and voluntary sector services, that it is difficult even for professionals to keep a track of what the services are, to know where the gaps are, for example, let alone for patients to navigate and for carers to navigate. So the intention with this in May was we set ourselves an ambition to produce a whole system resilience plan. Wasn't something that we had to do. We are told to do a lot of things in health and care. This was one of the things that we decided to do for ourselves, essentially to make sure that we were all clear on what the service provision was, to invite ourselves to consider, well, where are the gaps in services and what can we do that needs to be better. So I suppose there's a point of clarity, just picking up on the comment from the Older People's Assembly colleague, that it wasn't about developing or designing new services. It was about making sure that we are clear on what our plans are going into winter, but also it was an opportunity to give a wider overview of all services on offer. So core health, core adult social care, voluntary sector, prevention, screening, vaccination services that were already available. We weren't intending to change any of those services through that process. In terms of making that available, you can see it says in the document that plans are being finalised. That is because there was a number of areas where we did indeed identify some gaps. So, for example, some of the end-of-life care provision wasn't properly described. So we are just sort of pulling that together. But I see no reason why we can't publish that, make that available publicly. So I'm happy to take that action if that would be helpful to colleagues. In terms of the other items, one of the areas that we talked about at the October meeting was developing an integrated prevention offer. So we have 6 priorities as a place board. Number 4 is about developing an integrated prevention offer for the city, all age, through the life course, supporting people to start as well as they can, live as well as they can, age as well as they can, and essentially narrow the gap in terms of the healthy life expectancy. We know there is a gap in actual life expectancy, but the gap in healthy life expectancy is even greater. So that integrated prevention offer is all about us working across health, care and public health to join up our planning, make joint decisions around the York pound, if you like, and deliver a better outcome in terms of those services. Again, partly down to the complexity. We often don't know actually what is available, and I think the sense was, if we do this right, that we can improve the value for money from the collective York pound and improve outcomes by that targeted approach to those that actually are in the greatest risk categories in terms of poorer life or shorter life expectancy. So that's really exciting to see, I think, as a place board. We are not a statutory body as a place board. We are a new entity. We are still finding our feet, I think, as health and care leaders, working in a different statutory environment, working in a really pressured and changing environment. So this would represent, I think, an exciting prospect in terms of genuinely joining up our planning and decision making around funding and investment and service delivery for patients and residents. So more on that, I'm sure we will provide at a later date. I'm not going to highlight everything, I'm conscious of time, but what I did just want to do was to draw attention to the patient story that we had at the place board. And you do have some information on this because the minutes are there, but I just wanted to highlight this. So we had, and apologies, I've got to forget her surname, but Sharon from the York Carer Centre. Is that Sharon Smith? Thank you. And a lady who accompanied Sharon.
Karen.
Thank you. Thank you, Chair Karen. We're doing an excellent job of teamwork here. So Sharon and Karen came along to the place board and delivered some really strong messages that I think were really important for health and care leaders to hear. And I just want to read some of those, the things that we heard. So just highlighting that within York, a small city really, when you think about it, 6,248 people in our city providing more than 20 hours of unpaid care a week, and 3,803 of those people doing so for more than 50 hours a week. And when you just consider that in terms of free health and care hours, it's incredible. Arguably our largest workforce. Nearly 1/3 of NHS staff are carers. I'd be interested to know what it is in other public sector services. So 31% of NHS staff are also caring, and you consider the number of hours that they're working and caring per week. 1 in 7 people in the workplace are juggling work and care. The Joseph Rowntree Foundation highlighted carers as one of the groups most likely to be in very deep poverty. 60% of carers report a long-term health condition or disability compared to 50% in non-carers. So caring is a risk factor for poor health. And if we think about what we were just talking about in terms of healthy life expectancy and where those gaps are, and this is one of the drivers. And young carers are more likely to report severe psychological distress. And I'd be interested to know the life chances of those young carers and what are we doing as a city to ensure that they have the best possible start in their adult lives. And actually think about the amazing skills and experience of those individuals and the characteristics that they will represent in terms of adult members of society. And are we doing everything that we could to support them to fulfil an adult life? So in York, through our Population Health Hub, we are taking heed of that and responding. So first of all, it starts with recognising carers as part of our targeted population groups to ensure that we are designing interventions that support them to lead healthier and fulfilling lives. Also, we heard from the Carer Centre, and a number of actions were agreed by the committee as a result of the conversations that we had. So we agreed as a place board to ensure unpaid carers are included in every strategy and all decisions made. That unpaid carers are listened to and respected as equal partners across all health staff. Whether or not carers awareness training could be mandatory across all healthcare settings. The ICB to host a resource pack for primary care with NHS England. And just to say that the York Carer Centre will be coming back to the place board. We've actually asked them to outline, almost be a bit bolder in their ambition to come back to us and ask, what is it that they need from the system? Just an action that I've taken as well, Lucy, it might not have filtered through yet, but Simon Moore actually wasn't at the meeting at Place Boss. I promised I would give him an action, and the action was for him to go first in terms of ensuring that unpaid carers are indeed listened to and respected as equal care partners. And I'm pleased to say that Sharon has been invited to one of the York Hospital patient experience forums with staff to talk through their experiences and what they can offer and what support they could need. So I just wanted to share just a little bit more around that experience. I think it is something that we don't talk enough about, and that we can do a lot to support. So thank you, Chair. They were the points I wanted to raise. I'm happy to take questions and then come to the video shortly.
Brilliant. Thank you very much, Sarah. I actually went to the Carer Centre this morning and reminded them that they needed to come back with a serious set of asks of the Health and Care Partnership, and that you were open to all the asks that they might have of you going forward. I just thought it was important to remind them that because Karen was there this morning, that's just how I remembered her name, so I saw it this morning. And one of the things I picked up from them just this morning, which I'll just take the liberty of sharing, seeing as we're in a public setting, one, absolutely reiterating the poverty challenge, and we're talking about the cost of living a bit later on, but the poverty challenges and the cost of living challenges for unpaid carers are significant. Maybe one for the hospital to take away was the John's campaign around parking charges at the hospital for carers, particularly those carers of dementia parents or partners who I think John's campaign means that they now don't pay for parking if they're in the hospital for a considerable period of time, but you have to get it authorised through the ward. And so therefore, just whether there was anything from a comms perspective that the hospital could do just to improve awareness of the fact that that support is available now for carers across the city. And similarly, just on your numbers, Sarah, just on carers, the hospital has unpaid volunteers who work across the hospital trust, and this morning it was explained by Christina, who does a brilliant job at the hospital kind of and across the trust, I think, supporting the patient experience at the hospital. They have the equivalent in volunteers of 37 full-time equivalent staff at the hospital from their volunteering volunteers. But actually, if you equate that to the carers on top of that, who are actually also at people's bedsides, making sure that they're eating, making sure that the records are right and that medication is being checked properly, actually that will be infinitely more than that. And so anything more on carers that we can be doing to just make sure that we're appreciating the role that they're playing, I think would be really appreciated. But thank you for a very comprehensive update. Does anyone have any other questions or comments they wanted to make on item 6 around the Health and Care Partnership? Is that Zoe's hand? Zoe?
Yes, thank you very much. Yeah, just to say that obviously carers are a big part of TUV and our hospital at Foss Park in York as well. So as with our partners in acute, we do a lot of work and a lot of training with our staff in the hospital about how to involve and engage carers, and we very much want to be part of this conversation and to be heavily involved in it all. So appreciate and absolutely welcome everything that Sarah's just been saying, and we as I say, just want to reiterate on the public record that we wish to play our part in that.
Thank you, Zoe. Does anyone else want to come in on the Health and Care Partnership? In which case I will move on, but obviously not before just saying to Sarah, just asking, when you talk about gaps in services, for a quick update, perhaps not now, but perhaps at the next meeting on dental provision. I know we have a meeting in the diary around dentists and oral health. I think it's next week. But if it was possible to have some kind of update included in one of your reports back to this board at the next meeting on dentists, that would be great. She knows.
In a second, but I introduce the video.
Lovely. In which case, let's, if no one else wants to come, you want to come in? Yep. If no one else wants to come in, we'll watch the health matter and then we'll move on to the next item on the agenda. Do I need to just approve this? Do we just receive the report? We just note the report, in which case, let's, if we can watch the video, that would be great.
Sorry about that. So just before we play the video, just two points. One is just to comment on the dental item. Thank you. Thank you. Thank you, Emma, for clarifying that I don't commission dental services. However, the ICB does commission dental services, so happy to take on that point. So I think in terms of technicality, it won't come under the Health and Care Partnership item because it's not part of the Health and Care Partnership's remit. However, in terms of the principle of having an item on dental, in terms of the I can't think of the word, but you know what I mean. We can certainly facilitate that, and we will have the discussion next week. As you say, we've convened a number of partners across the local city and also the ICB in terms of who is responsible for commissioning.
It's fair to say to some of the public participants that they are not alone in their complicated navigation of healthcare acronyms. I also still struggle, but thank you.
I consider myself as the sort of the resident dictionary for you all in terms of trying to explain the health and care system. So without further ado, we've had a very busy month in the place board remit. We had two quite big events going on. We had a workforce recruitment event, which involved lots of partners coming together, in fact, in this building around recruitment, and that was a public event. But we also had a fantastic event in September, the first Health Mela, and potentially the first of many. Let's see how things go. But what I just want to say is that this is about recognising the role of family, friends, communities, building trust and breaking barriers across our communities. And I think the video probably will say it all. So thank you.
Really nice to see so many people come together and celebrate. So a lot of people that they want about that was not needed there. What we witnessed here today is a really powerful and something, it's a celebration of the diversity of culture within on health.
Thousands of people have been here today, and the first of it, I thank you so many.
Fantastic, thank you. And thank you, Sarah, for all the work that obviously went into putting that event together. It was fabulous. I think I said to you a couple of weeks ago, if you want to make it an even bigger success next year, you'll have them queuing around the city if you have a dentist there. But no, hopefully plans are already afoot to do it next year, but it was a brilliant event, so well done, and thank you to everyone who was involved in putting it all together, because it was really nice to see all those services all in one place, with the whole city represented. So yeah, it was fantastic, thank you. In which case I think we can move on to item 7, which is the report on the health impacts of the cost of living crisis, and Peter Roderick is going to present the report, as is Pauline Stutchfield. She's like a special guest. Thank you. And have we got Heather Baker and Thomas Dolman as well? Oh yes, a whole star cast to present this report. Fantastic. If you want to do a presentation, and then if people have got questions or comments, we'll take them afterwards, if that's all right. So the floor is yours.
Thank you very much. Yeah, we have brought the casting through, but hopefully can answer all the questions that come from this report. My colleagues can introduce themselves. Many people will know Pauline beside me, who's from City of York Council. The work on cost of living is really citywide. It doesn't affect just one sector. The rising cost of living is hitting every part of the public sector and is affecting a lot of communities. We probably don't need to go through that and rehearse it in too much detail. Just to say, really, before I bring Tom and Heather in on the report you've got in front of you, that there's a whole ton of work that happens at a city level. Pauline might describe little bits of it, but this particular piece of the puzzle is around the health impacts of the cost of living. We know that there's countless pieces of work going on around financial strain and inclusion, a lot of work that goes on about warm homes and making sure that we protect people as possible through housing. This report focuses on one bit of that puzzle, the health bits, pulls out some of the things we're seeing in some of the data from GP services, from hospital services about how the rising cost of living and financial strain is affecting the health of residents. It really complements the work that Health Watch have done when it comes to the cost of living. I just want to say that for me, those two things come together. We've had conversations as a board previously about this, and very much that the board were interested in having a continuing conversation that had both the voice of residents and the experience from, I guess, a qualitative point of view, but also from seeing, well, what does that actually mean and things we can measure in terms of people's health, and how do we join those two bits together? So that this is very much focusing on that second half around the health impacts and the data. I'll hand over, I think, to my colleague Heather, who's going to talk a little bit, and Tom as well, about this report, some of the things it says, and then Pauline may wish to add some comments.
Thank you, Chair. So my name is Heather Baker and I work for the Public Health team for City of York Council. I also sit on the Population Health Hub, which, as you know, is a multi-agency hub that pulls together representatives from the council, the ICB, the hospital, and the care and voluntary sector. We published a cost of living crisis pack last year, and this is really a continuation and an update of that report. And really, it's pulling together a lot of that quantitative data that might suggest a correlation in people's health and the health impacts relating to the cost of living crisis. Earlier this year, the London School of Economics declared the cost of living crisis to be a public health emergency. And this is as a result of some people's inability to afford even the basic essentials. And that can therefore have a far-reaching consequence to both physical and mental health. And there's quite, the wider determinants of health are quite a long established pieces of evidence that impact on people's health. And this is really sort of a continuation of those aspects and those factors. So things to do with housing stability and affordability. Can people afford to rent a 2-bedroom property in York? Can people afford to heat the house, or do they have to choose between eating and heating? How is the impact of living in a cold home affecting long-term health conditions such as arthritis? And also household debt, disposable income. We've had some data from Citizens Advice York around the various calls that people make around debt insecurity and going into rental arrears. And also some wonderful data from the food bank charity here in York around people's access to food banks and food bank vouchers, and the uptake per ward on over the past 4 years. And so I'm going to hand over to my colleague Tom from the ICB now, who's just going to explore some of that data in a little bit more detail. Thank you, Chair.
Hello, hi, Tom Dolman, Population Health Manager at the ICB York Place. Yeah, absolutely. Within that London School of Economics model, there are the various headings of housing and stability, food accessibility and consumption, fuel transport, household debt and energy use. And for each of those areas, we were tasked to go away and look at data to support a narrative and to look at the health implications. What became very quickly apparent was that it's very easy to find data on the rise in price of fuel, but it's quite difficult to pull data to suggest that whereas we know in academia that there's going to be health implications as a result of that, but to have the raw data at a local level to get hold of that has been difficult. Some of the headlines that you'll see on page 3 that do support that there have been health implications as a result of the cost of living crisis. We can see that 1 in 9 York children are living in poverty. We've seen that there has been an increase over the last year by 3.8% on mental health attendances. We've seen 69 homeless households in temporary accommodation in 22-23, which further down within the pack, you'll see that that's a rise year on year. We have access to primary care data, which has been invaluable in looking at the real-time impacts. There have been 698 events in primary care relating to substance misuse between October 22 to 23. Asthma control is 6% worse in children living in deprived neighbourhoods. We have 167 children with asthma that are passive smokers. And we have 55,496 residents living with a long-term health condition. And we've seen an increase of 26% more COPD exacerbations recorded in primary care between January to March 23 than in January to March 22. So without wanting to go through each individual chart, really happy to answer any questions about the mechanics of extracting that data and some of the implications.
Pauline?
Thank you. You won't be surprised that the council considers that we're in a cost of living crisis. Fortunately, we've been working on a partnership basis on financial inclusion for quite a long time in the city, and we've got something called the Financial Inclusion Steering Group. It's still called that, Councillor Runciman, since you've been on it, and we're still thriving and growing as new partners join that partnership, and we have an internal officer group as well. The new administration of the council regards affordability as one of its 4 core commitments, and the work of the Financial Inclusion Steering Group and Internal Officer Group both feed into the affordability update to executive members and corporate management team every 2 months. So they're getting a live feed into what's happening on the ground. We had a Financial Inclusion Steering Group last week and had a real focus on data, and not surprisingly, lots of the data in this report corresponds with the findings that came out last week. The key issues are that we're finding that all organisations are seeing new presentation of people that they've never seen before, who are new to debt, and essentially seeing a lot of mortgage issues and also credit card debt emerging in their data. And again, Citizens Advice York are the organisation that tends to be the source of a lot of our data, as well as our own benefits information. People are presenting with increasingly complex needs, and particularly mental health conditions. And as we know, mental health conditions can feed into an inability to be able to deal with the impacts of poverty, and equally poverty can lead to mental health conditions. We're seeing illegal money lending and coercion, that's the right word, isn't it? As a key feature. Digital exclusion, as people are unable to access the support they need online, as Councillor Runciman mentioned earlier, and pressure on all partners and community voluntary sector, as we're seeing more people feature and access services. The good news is that, as I say, we are well placed as a partnership to meet the challenges of such issues. We have 90 linked advisors working across partners across the city, set up to share resources and training. We have a number of Talk Money weeks across the year, not just the one that nationally is featured. And we have a Managing Money leaflet that we use across our partnerships. We have our excellent Live Well York website we use on a partnership basis. And we continue to distribute available funds on a cash first basis for food and fuel support, and the ongoing development and support for our warm spaces as community hubs going forward. And more recently, we've had the launch of the York Community Fund, which means that York people can fund York causes and voluntary and community sector. We're also developing a partnership-based 10-year anti-poverty strategy that's just fresh off the council plan. So hopefully you'll all be involved in the development of that. So I'll leave it there. If there's any questions. Thank you.
Thank you. Peter, did you need to add anything else before we open things up?
I don't think so, Claire.
Does anyone want to come in?
I was pleased to be able to serve on the Financial Inclusion Steering Group for some years, and I think the support that they give is really important, and it's a matter of coming down from thousands of pounds to say £100, which can make a tremendous difference to some families. So I hope both the government, and the local authority will continue to support the Financial Inclusion Steering Group, because I think their work is really important.
Thank you. Emma?
Lovely. Thank you so much for this report. I think it's really powerful. I sit here as a local GP, very much able to reflect on all of those things because we're seeing them day in, day out. Each one of those in itself, they're not easy fixes. So children with recurrent respiratory illness, when you can't do anything about the damp that they're living in, it not only creates powerlessness, but the whole impact is so wide. The drug and alcohol misuse element is something, again, we're feeling very strongly on the ground, and those are the hardest things to fix. And we've got, just to kind of come back about what we're also trying to do at the York Healthcare Collaborative, where we pull together all the different partners. We've got our next workshop is on dual diagnosis and drug and alcohol problems, because they are growing and they're real and they're the most complex in the system. And we know from your population health hub data, thank you ever so much, that combine SMI and substance misuse and a couple of long-term conditions, and the revolving door and the cost just spirals. So I think it's very important to call out these things are happening now. None of them are easy fixes. So it's a really sober report to read, isn't it? And I mean, sad to look at over 10% of our children living in poverty, when 10 years ago we were nearly a poverty-free city. Sorry, I'm just going to express a lot of sadness to see that. And I think it's really important we vocalise that. So there's a lot of sadness in reading some of these figures, but they're real. And I guess it's just trying to pull providers together. We need to look at what we can do within the resources that we've got, can't we, at the moment, to try and mitigate the impact it's having on the most vulnerable in our community. Certainly, I know that Live Well support, we did a big campaign last year just from primary care. I know I'm going to say digital here, but we did send out to a large number of families under 5 just access to this, because any bit you can do to try and help direction for financial support. We've used obviously the social prescribers. It's an awful lot to try and help with this, because obviously the social problems then cause the medical problems, which then compound the situation. So again, it's a big so our workshop next week is very much focused on this at the York Healthcare Collaborative. And I guess the important bit is to keep sharing the data and also sharing what is available, because that's all we can do, is use the resources we can and try and signpost people to them, because I think at the moment there's a lot of feeling of hopelessness out there in the community. There's a feeling everyone is overwhelmed, mental health services, primary care services, every service around. So how can we focus to make impact, I think, is a real challenge. But anyway, I really, so thank you for pulling this report. It's really important to share.
Thank you, Emma. I'm just going to go to Mabs Hussain from North Yorkshire Police first, and then I'll come to you, Sarah.
Yeah, thank you, Chair. And again, I reiterate the comments that have just been made. I think it's a really, really good report. It's a really powerful read, in particular when you look at some of the data that's contained within Annex A. As you would probably suspect, I start looking at this from the lens of vulnerability and the causation factors for crime. And although the report doesn't make the direct link, which I think there's opportunities to do so, a lot of the areas where we are seeing in terms of increasing crime, in terms of what we would call lower level crimes, there are linked to things like shoplifting, people stealing packs of washing powder, things that we've not normally seen. You know, we always see the meats and things of that nature, and because they're easily sellable goods, but we are seeing other items that are now being stolen. And the reason for that is because of the cost of living crisis, but there are also some vulnerability factors that I think there is an opportunity to have a look at, which is then a causation factor for young people in particular coming into crime, and other people suffering from other areas of challenges in their personal lives, then either becoming a victim of a crime or actually committing crimes themselves due to some broader mental health issues that, as the report outlines, and coming to the attention of services like the police. So I think there is the opportunity to join us in a much broader sense, but also when you start thinking about the mayoral combined authority next year, the opportunities that devolution brings, some of the investment opportunities, in particular in deprived areas, priority ward areas, and how we can then target investment in areas to create better social mobility and protection around certain communities and age groups. Thank you.
Thank you for that. Sarah, did you want to come in?
Yeah, thank you, Chair. So thank you, Peter, and thank you, team. I just wanted to make a couple of comments and probably just one question. Just to say, we're really lucky to have this resource in York. Not every place, for example, has a population health hub, and I want to encourage every partner to make full use of our population health hub. And I'm eyeballing a number of kind of statutory service providers around the table in terms of this is a great tool for us to be able to really understand the intelligent actions we can take as a city to target investment to the areas of greatest need. And actually, it isn't rocket science if you know the people behind the numbers. So if we look at the chart on page 10 in the report, page 77 in the pack, the A&E attendances and admissions for respiratory conditions, behind that are people, our families, our households, and we can target them. So the population health hub is about bringing together all partners and then using that data to design interventions. So I just want to encourage all partners to make use of the population health hub. Also, just in relation to targeted investment, the ICB, I've talked a lot about healthy life expectancy. Well, that is the ICB's vision. And nationally, there were some health inequalities, additional allocations around health inequalities, and they were made available last year. The ICB has agreed to commit to funding that for the next 5 years in terms of ring-fenced health inequalities funding, designed to develop and support targeted approaches to reduce the burden of ill health and narrow that gap in terms of healthy life expectancy. Now, a good proportion of that has been allocated to place-based partnerships, and the responsibility for that sits with myself and the Director of Public Health. Again, the Population Health Hub is absolutely key to being able to obviously support us with the data to target those investments. So I just wanted to make the board aware of that. Well, actually, one more point. Just building on the point that my colleague online made just a minute ago. We are also just embarking on conversations with the fire service, for example, and we mentioned just a minute ago police services. It is the same people who are vulnerable. It is the same risk factors across all services. Tom Dolman, who is in the room with us today, he is just starting to some exploratory work with fire service colleagues. How can we work together through sharing our data to improve joint planning and joint delivery? It's the same people. So we've talked about resources being incredibly stretched. We've talked about rising demand and the difficulty in meeting all of that demand. These are the kinds of things that will make the difference to us being able to meet as many demands as we can for our residents. My final point and the question is that this is a really fast changing picture, isn't it, in terms of the impact of cost of living, and we are going to keep seeing those changes over just in weeks and months. We've got Christmas coming up around the corner. We've got no doubt winter spells coming up. So my question is to the team is, are we thinking about, or what mechanisms do we have in place to almost in real time look at what the data is telling us and potentially respond in real time in terms of additional actions to target communities this winter, rather than using the data for next winter.
Yep, Peter, do you want to come in?
I would thank you everyone for the comments on the report, and to pick up that question directly, Sarah. Yeah, I absolutely agree with you. I think there's a certain extent to which you pull it all together at regular occasions, but in between you want to have some of that live data. Pauline would just tell the story better than me in terms of the council's understanding of financial burden, stress, what we're seeing through the customer centre, what we're seeing through our routes in through welfare and benefits and advice. Citizen advice certainly can speak for them, because I've seen the use of their data is really good, actually, the way they pull together and understand the services and the advice that they're giving, the types of issues that our clients are coming up with. So I think that real-time data does happen. I think there's probably something about within health, the way we use what we're seeing in the two sort of crunch points of the system, which is GP front door and A&E front door, and responding in real time. So what we are going to be doing at the next meeting, the Population Health Hub, is having a bit of a show and tell about what is happening, particularly from a winter perspective, about the front door of A&E and the front door of GP services. What are the rising issues that patients are bringing that we maybe are not expecting? For instance, are we seeing more children and young people with mental health issues at the front door of A&E than we did last year? Those sort of hypotheses that we think may be happening, we are keeping tabs on through that group. So I think the real-time monitoring happens. It doesn't necessarily get put into pretty pictures as often, because in a sense we're trying to respond, but the reports pulling together like this, I would definitely say we could look to revisit this type of thing at that regular occasion, possibly at this stage when you're just getting into winter and you just need to know what the final bits and pieces of a winter plan need to be put in place to protect the public as much as possible.
Thank you, Peter. Just a couple of things that I picked up, and apologies, one of them is related to the previous report, which also had the work of the Population Health Hub in it. And in one of the links, there was a, which I, given that you're here, I thought I might take the liberty of asking you. There was a reported good health variations by ward map, which normally I would have thought I could have predicted by now, but actually it was quite surprising. And I just wondered, sorry to put you on the spot, but and we can pick it up separately if that's easier, but there was, it didn't entirely look like it was what I was going to expect to see. And I wondered whether there was either an age factor or a poverty factor that was overlaid on one of them, that meant that actually the wards where you would have expected reported good health variations, where you would have expected higher levels of good health, actually it wasn't, and areas where I would have expected to probably have seen poorer health, it wasn't quite as bad. And so therefore I just wondered whether there was an overlay of either poverty or age on one of those factors around good health reporting. But you don't need to answer it now if I've completely put you on the spot.
I would definitely like to look into that, but yes, if we could take that away as a separate conversation.
Please do. And then just separately for me, just to echo the points that have been made around poverty and health, and the fact that this report picks up on a lot of the impact of that. Just to pick up on Pauline's point around the EACH principles, and affordability is one of the EACH principles, but health is also one, and therefore just, you know, the link between money and poor health, I think this report picks out very clearly. Although the number 1,343 residents living with mental health conditions in deprived neighbourhoods, that feels very low to me. But maybe that's an increase. I don't know, but it is hugely challenging in terms of the financial environment out there, and you know, we as a local authority hugely appreciate all the efforts that are going on across the system, whether it's in the voluntary sector, whether it's in health, whether it's in statutory council services, to try and everyone's doing their best to support residents to the best of their abilities through the crisis, which is ongoing. My question, I guess, was, is there any evidence of examples locally when for whatever reason, someone's personal circumstances of financial crisis ease and it has a positive impact on their health, just the kind of reverse of what your charts are telling us really, and whether there's any evidence that we all think that the direct link between cost of living crisis and poverty and poor health, it seems pretty clear, but whether the inverse is also clear, that actually if your circumstances change, your health improves. I don't know whether anyone's got anything they can add on that.
Well, I'm just happy to pick up that it's an interesting hypothesis. You'd hope so, wouldn't you? I expect citizens' advice would possibly be able to help us on that. And I think it's about making the point that one of the tragedies is how much of the sort of the benefits entitlement are not picked up by people who are eligible. So one of the key bits of the actions from all of this work is to take every opportunity we have within healthcare to make sure that people are signposted into financial inclusion and advice to make sure they're getting everything they're entitled to. And I expect advice services would be able to tell us that about, once you've got someone on the right benefits and receiving more money they're eligible to, potentially you could measure it in terms of the number of return visits they have or the number of times they're coming to the GP, but not aware of any local evidence that we've got on that. You just have to hope that if these are it going the wrong way, that it will be true in reverse, I guess. So Pauline, you might want to add.
There's a couple of things really. We obviously, as part of the local area coordination service, record resident stories and where we've been able to impact on someone's life collegiately across partners. We're able to tell that story at the end point, and of course we're very, very interested where we've been able to avoid going into statutory services. We're also trialling a tool called Policy in Practice, which helps us collect all of our data around our residents, and we'll need to talk to yourselves about that, to be able to feed into a gap analysis of where people are not claiming. And the benefit of that tool also, it tells us where people have gone on then to improve their financial position. And I don't know how then we can correspond that with their health long term. We probably need to think about that.
We could take that away as an action point. It's always harder to combine health and non-health records than one might think, but it's not impossible. So if it doing so produces evidence which leads you to change, I think it's worthwhile.
Great, thank you. So we are asked to. Did anyone else want to come in? I haven't seen anyone. Oh yes, sorry, Alison.
I was just going to say about the social prescribers could probably give you some of that evidence of once they've helped somebody get themselves back on track financially or what have you, they could demonstrate any improvement in their health. So I will look into that for you.
Hugely appreciated. Thank you, Alison. We are asked to note and discuss the contents of the report. We've done that. We are going to be disseminating the findings and support available in York to local services and practitioners in York, so that it's available more widely. I think it would be great if we could do that with an offer of kind of conversation with people if they've got things they want to share back to us in terms of either evidence or examples or anything else that plays into the great work that has already taken place, but just widens the picture slightly. I think would be great to include that. But it's a really good report, so thank you all for all the work that you have done on it. Long may it continue. And we can move on, I think, to the next item on the agenda, which is agenda item 8, the Health Protection Annual Report, which Sharon is going to present for us. And actually, we are just about on time according to our new timings. So I'm doing okay, but I'm not yet as a star, am I?
Thank you, Chair. Members of the board will recall that this is a report that comes to the board every year. And the purpose of the report is really to provide Health and Wellbeing Board members with assurance of our health protection arrangements. You've got quite a detailed report in your papers with lots of graphs and figures. So I'm not intending to go through that in any detail, but happy to take any questions either this evening, or happy for people to contact me by email if there are any specific questions. Just a couple of things I wanted to tease out. The health protection system is actually quite complicated, in that different organisations and partners across the system are responsible for different bits of health protection. Which makes it a bit of a challenge for the Director of Public Health at times, who has the statutory duty for making sure that these arrangements all work for the local population. So if I say, I'll just go through page 84 and just summarise those arrangements. So within the council, the Director of Public Health works quite closely with other teams across the council, particularly the Public Protection team, environmental health teams, trading standards and emergency planning teams, but also teams in planning as well and licensing. So there's quite a lot of work that actually happens across the council teams. But then we've also got the ICB, the Humber and North Yorkshire ICB, that has some responsibilities. So we work jointly with the ICB and North Yorkshire on commissioning infection prevention and control services. This isn't the service in the hospital or in TÜV, because they're responsible for their own IPC arrangements, but the IPC arrangements in communities. So when we think about care homes, domiciliary settings, schools, community services, those are the shared responsibilities across the ICB and local authority public health teams. The ICB is now a statutory organisation, so it's also become a Category 1 responder. So in paragraph 9 there, I talk about the Local Health Resilience Partnership. So there used to be 2 LHRPs, one for Humber, one for North Yorkshire and York. That's now been combined, and there is one ICB Local Health Resilience Partnership, which brings together the system responsibilities really for emergency planning, preparedness and response. So I co-chair the Local Health Resilience Partnership with Amanda Blaw, who's the Chief Operating Officer within the ICB. And the LHRP has a really important role in bringing together NHS trusts. It also brings the local resilience forums together, as well as the UK Health Security Agency and local authority public health teams, so that when we're thinking about the NHS and care response, we've actually got that body that provides that oversight, and the body is also responsible for assuring local plans across the system and for testing those plans. I think it became very apparent during the response to the COVID pandemic how important that system-wide working is. The UK Health Security Agency, then UK HSA, is a national body. It has responsibilities for the more specialist areas of health protection, but also has now established a Centre for Climate and Health Security, recognising that climate change is really a public health emergency that is having significant impacts on people's health, adverse weather events, whether we think about cold weather or heat waves, or other impacts of climate change, have a significant impact on health. So UK HSA is leading some of that work. And then local authority directors of public health work very closely with UK HSA in responding to any particular incidents we've got locally. NHS England then is responsible for commissioning and quality assuring population screening and immunisation programmes, and there are a range of screening programmes that are detailed in the report. The local authority director of public health also has responsibility for ensuring the quality of immunisation and screening programmes and an uptake, and particularly looking at work to tackle inequalities in uptake of screening and immunisation programmes as well. So because of that complexity, and taking some of the learning that we had from our response to COVID, it was agreed that we set up a York Health Protection Committee that is chaired by myself as DPH, Peter going forward as the incoming DPH. That committee works very well. It's very well attended. We get into some quite interesting discussions. For example, one of the discussions we had at the last Health Protection Committee was about access to seasonal flu immunisation and COVID-19 vaccination for non-clinical staff in special schools, for example. So it has a practical focus, I would say, as well as responsibilities for ensuring that our health protection arrangements work. So the report goes into quite a lot of detail about progress over the last year, and it also highlights quite a wide range of recommendations for the coming year as well. And when the Health and Wellbeing Board receives next year's report, you'll be able to see the progress that's been made against all of those recommendations. So the Health and Wellbeing Board Chair is asked to receive the report, and it's really so that members can be assured that our health protection arrangements, that we've got robust arrangements in place, and be assured that they're working. But happy to take any questions.
Wonderful, thank you. And it does feel like, you know, after the last 3 years, this feels like probably has become an infinitely more important report to analyse and be aware of. And thank you, and I know to the other members of the team who have huge input into this work all the time, and we're all very grateful that someone is keeping an eye on outbreaks and infection rates and vaccination rates of things, so that if we need to, action can be taken. Does anyone have any comments that they would like to make? Councillor Runciman.
Thank you. One comment and one question. I was delighted to see the supervised toothbrushing I think that's an excellent idea. Many years ago, I worked with the British Dental Health Foundation to introduce preschool children to toothbrushing with an enormous set of teeth and a very large toothbrush, and it went down a storm. Because of the lack of dentists, I think that supervised toothbrushing, I hope, will roll out wider. And then the other one that's slightly concerning is the uptake of vaccinations. I am concerned about measles coming back. My worry always with childhood disease is that people think they're not very important, and of course they are very important. And I notice MMR is slightly below the hoped for level. And I wonder, Sharon, if you can explain what we're doing to try and increase the uptake, not just of that vaccinations, but of vaccinations in general.
Yes, sure. One of the there are two groups that really focus on vaccination and immunisation. There's the ICB has a vaccination board that's chaired by its director, the ICB Director of Nursing. And then in York, we also have a subgroup of the Health Protection Committee that really focuses in on vaccination data. We have lots of data, including practice level data around vaccination uptake. It is a constant battle, I would say, to try and encourage uptake. I've noticed the impact of social media, particularly, and a lot of negative reporting around vaccination. We saw it to a large degree during the COVID pandemic, but we're still seeing it to a degree now. So it's a constant focus to try and get out communication messages right, and to try and myth bust some of the information that's on social media. A particular focus at the moment is on seasonal flu and COVID-19 vaccination uptake. It's always quite good for older people over 75. We always have very high coverage rates in York. But I was looking at the most recent data this morning, and there is more we need to do, particularly with the younger age groups where people may have long-term health conditions or other factors that mean they're particularly at risk of seasonal flu or COVID. So that work is continuing. On measles, there is joint work happening across GP practices and, again, the ICB and locally around measles. So there's letters that have gone out to all NHS trusts, for example. And we're looking at it at a number of different levels. First of all, looking at staff. Measles, whether staff have measles vaccination. In my nursing days, it was mandatory to have a measles vaccination, for example, but that's a long time ago and things have changed since then. So it's very much voluntary for staff to take up immunisations. So that's one of the things we're looking at for measles. We're also using the practice level data that we've got to work with those GP practices where the uptake is lower, to look at how we can improve that. We're also working with the school vaccination programme to do a catch-up programme of children that haven't had 2 doses of MMR. And then the other bit of work we're doing is particularly targeted around refugees and asylum seekers. We know that they're at high risk of the measles outbreak. If we're going to have a measles outbreak, it's more likely to be in our traveller community or in our refugee and asylum seeker population. So we're doing some targeted work there as well. So lots of work going on. Time will tell as to whether that really makes a difference in terms of vaccination uptake, but certainly that's some of the work that we're doing at the moment.
Sorry?
You might want that data back at some point, might you not? Yes.
Martin.
Thank you, Chair. I guess there's possibly an opportunity, certainly from September 2024, where we see the rollout of free childcare for from 9 months. So whether we work with some of our early years providers in the city, both childminders and early years settings, because obviously at that point there will be many more young people, many more babies, children, accessing settings than there are now.
Sharon.
It's a really good point, Martin, and we already are, for the reasons that you describe, really. You know, that's part of our communication strategy, certainly. There's also work that's happening with children's social services as well, particularly around children who might be subject to plans. But you know, any additional support is very welcome. So any suggestions from children's services will be very well received.
Thank you. And because I've just been told that we're running over time, I'm going to, we're asked to receive the report, which we have done. I will add to it some thanks to Sharon and her team for all their thorough work on this for the report, but also all the time to keep us all safe. So thank you very much for that. And I'll move on to agenda item 9, which is the joint health and wellbeing strategy update. And Peter is going to speak to the report. Peter.
Thank you very much, Chair. And yeah, before I do, 30 seconds if you indulge me for just a really quick personal thing, which is to thank Sharon. This is your last Health and Wellbeing Board, I think, Sharon. So I know, Chair, you were going to make some comments to, I think, the end, but just to add my thanks to Sharon, having worked with you for a number of years, particularly during COVID. It was fun, wasn't it? I don't know if that's the right word, but there was lots to do and you've done an exceptional job at it. So just to acknowledge your hard work and what you've done for the resident citizens of York. So thank you so much for that. I'm just quickly going to go through this report, which is the second time we brought a report to the board on the performance against the health and wellbeing strategy that we launched. It's a strategy that lasts for 10 years, 2022 to 32. And we set in the strategy 10 population health goals that we wanted to achieve, 10 evidence-based ways in which the health of the population of York we wanted to see change and improve and would get us closer to our overall goal, goal number 1, which is reducing the life expectancy inequality gap. We talked about that first goal last time and presented some data. So this update is on goals 2, 3, and 4. Goal 2 is around what you might call population mental health, how we are as a city when it comes to general levels of mental well-being. And there has been a couple of pieces of data that we've been reporting on through this. One is around anxiety and the way in which we measure that every year through the ONS questionnaire, and again through the same questionnaire, what's called low happiness. Both those measures, York is still tracking beneath the national average. So essentially more people who are anxious and more people who report low levels of happiness. In fact, what we saw very recently within ONS's data was that the COVID pandemic brought those figures down, as we might have expected. People were less happy during the COVID period. 2022 saw a bump and actually went back up. And unfortunately, 2023 has seen very recently released data that the national figures have gone back down. York has pretty much tracked with national figures on that. So the paper sets out some of the actions that we set ourselves 3 actions. There are some updates around the Community Mental Health Hub, updates around embedding a trauma-informed approach to the work we do across mental health and other services. And the third action is around supporting the VCS to capitalise on community assets in terms of increasing people's mental health and well-being. So we have some narrative against that, which I hope will be interesting for board members, and some progress on each of those areas. So we keep on monitoring that as part of our work. The second, or rather the third action, the second for today, action priority area number 3 was around smoking, the single biggest preventable cause of death, still in York, affecting 8.7% of our citizens, so about 17,000 smokers in York. Still, the proportion of the population who smoke from a routine and manual occupation is twice as high as the general population. The proportion of those with a mental illness who smoke is 3 times as high. So we still have significant inequalities. The prevalence is going down, and it's going down faster in York than elsewhere. Correlation, causation, etc. There are many more factors, but I think the fact that our Stop Smoking service has the 4th highest quit rate in the country is very helpful there. But there are other factors involved. People will know that more people are vaping nowadays. People will know that some of the regulation around tobacco is very tight, and would take this opportunity to say we have 2 weeks left. As a public health professional, I strongly support the intention of the government, which is currently being consulted, about increasing the age of sale by 1 year every year, so that no child over the age of, well, no one born after 2009 is able to smoke. I think personally it's one of the most exciting public health measures that we've had on the table for a number of years. So hopefully smoking should go in the right direction in terms of the health of our citizens over the next few years. The narrative in the report talks a little bit about some of the work we do around helping people quit smoking, but also some of the wider work around illicit tobacco and vaping, because we are very concerned about the rise in children and young people who are vaping, and we want to have that very delicate balance, helping smokers to quit smoking, and often that will be with the use of a vape, but also making sure that children and young people don't use vapes. The simple message is, if you don't smoke, don't vape. And that's certainly what we're putting out through a lot of our work. The third area is around alcohol. Still, we have 1 in 5 adults in York reporting drinking over the recommendations of the Chief Medical Officer of 14 units a week. We have a programme, it's here, Lower My Drinking, which is one of our key public health programmes, which produces lots of work around alcohol. We still see higher rates of hospital admissions due to alcohol, both for males and females, and that's covered in the pack. And the narrative talks a little bit about rollout of alcohol brief advice and intervention. It talks about Lower My Drinking, the campaign, including the app. We had 7,000 people take the Lower My Drinking quiz in January, because we worked with primary care to target people and let them know about the risk quiz. The quiz leads to a number of actions, and we certainly see bumps in services in terms of people self-referring, which is always very helpful. So hopefully some good work there, but plenty of room, I think, still for improvement on all 3 of those areas. So I'll finish there, Chair. Thank you.
Brilliant, thank you. I'll just jump in quickly before I open it up. Just one quick thing. Your goal 2, interestingly, I mean, we can see the challenge of mental health and anxiety, but given that we just also had a report on the cost of living, just reiterating the fact that we need place and economy to be around this table, because otherwise we're never going to sort out some of these challenges around the link between poor mental health and poverty and cost of living. Just on your goal 4 on alcohol guidelines, I had a conversation with Changing Lives this week about the barriers to accessing support, and whether there's a way of us widening the support that is offered in terms of where it is offered, to ensure that we are capturing not just what people perceive to be problem drinkers, the people that they might see propped up in a park, but actually, you know, people who are actually just drinking too much at home, and just those people may not themselves see themselves as problem drinkers, but if they did, I'm still not sure that they would see themselves as someone who would access a service in a place that they see as a place for drug and alcohol users only, and just whether there's a way of using either council space or other places where we can provide a more neutral venue that people might feel more comfortable accessing support that they might need. But I will open it up to anyone else who wants to say anything. Anyone? Peter, your work is done. It's all brilliant. No, in which case, thank you so much, Peter, for the report and the progress so far. What are we asked to do? We have to note and comment on the updates. I've done some comments. I'm sure we can pick it up separately as well, Peter. And we will continue to review the strategy. If people have thoughts on the parts of the strategy that don't come to a particular meeting, I don't think we're ever going to be particularly precious. If people have particular thoughts they want to pick up at a separate meeting, I think we'll be very open to that. But thank you, Peter, for your report and for your brevity, which I think means I've vaguely caught up on time. I have just about. And we reached the final item on the agenda, which is agenda item 10, and it is the final item on the agenda, the final health and wellbeing board for our outgoing Director of Public Health, who saw us through the pandemic. And I actually took the liberty of going back through some of your old health and wellbeing boards and annual reports just to see what I'd been missing. And particularly, I was struck by the annual report that covered the COVID pandemic and the amount of work that had obviously gone on across the council, across health partners, led in no mean feat by you, Sharon, and with other partners in North Yorkshire. So a huge thank you to that. I think, you know, you said in your report that you thanked the whole city for their efforts in going above and beyond what was required. Well, I think we'll put that back at you. We are also very grateful for you going above and beyond what was required in order to keep all of us safe during the pandemic. I will let you talk to your report, but thank you for all of the work that you've done in the pandemic and before and since. I will leave you with the floor to talk about your final annual report on domestic abuse.
Thank you. Getting quite emotional there. So yes, this is my last Director of Public Health annual report as the DPH for York on the very important subject of domestic abuse. And I'd just like to start by saying really that this is another example of work that we lead in public health, but requires all partners across the city to be involved in. And I think what the report attempts to do is highlight some of that work and some of the progress that's being made on this agenda. But recognizing that there is still a lot more work to do. So you have a copy of the report in your pack. If you haven't read it, I would encourage you to do so. But for the Health and Wellbeing Board, what you're asked to do this evening is to receive the report, to agree to support the 4 recommendations in the report, which is summarised on page 156 in your pack. Paragraph 7 there summarises the 4 recommendations that you're asked to support. And then in the main report, in chapter 7, starting on page 39 in the actual DPH annual report, you also have an update on the recommendations from last year's annual report, which, as Councillor Coles referred to, was our recommendations coming out of the COVID-19 pandemic. I would just like to finish by saying that one of the recommendations, the first recommendation, is around developing a new domestic abuse strategy. And that is a strategy that we're working on collaboratively with North Yorkshire and with our partners with the domestic on the domestic abuse partnership board as well. The reason this is a North Yorkshire and York strategy rather than just York is because domestic abuse doesn't respect geographical boundaries. And we felt that it was really important that we worked collaboratively on that. The strategy is progressing, and I'd like to make an additional recommendation, if I may, Chair, that the Health and Wellbeing Board receives that strategy once it's ready and has an update on the work that we want to do over the coming year. Domestic abuse is everyone's business. It needs everyone to be working on it, and I think it would be extremely useful for the Health and Wellbeing Board to be cited on that strategy and the delivery plan. So I'll stop there, Chair. Thank you.
Thank you so much, Sharon. Would anyone else like to come in on the report? Thank you, Councillor Runciman.
Just to start by echoing your thanks to Sharon. I've had the pleasure of working with her rather longer than you have. I've been very fortunate to do so. And then I want to just say about this particular report. It's about the input of the police. When it comes back, it might be that we ask specifically for input from the police because they are dealing with a lot of these cases. And Michael may have comment, and Martin for that matter, the input of the safeguarding boards who also come across this. So there's a lot more. I think Sharon started a debate here, which is an important one. There's a lot more that can be added to it from boards and organisations that already exist. And I would like to see that happen.
Thank you, Michael.
Thank you, and Councillor, you stole my thunder a little bit there. First of all, I actually would like to, thank Sharon, who's been, a great colleague and servant to York. So thanks for everything which you've done. In terms of the domestic abuse, really welcome the opportunity to have a new strategy in place, and particularly from a safeguarding adults perspective. We've seen really significant increases in the number of referrals and concerns that have come to us. And as a council, we have a particular responsibility to adults at risk who aren't able to protect themselves from abuse or neglect. And domestic abuse forms, a significant part of that for that cohort of people. So the alignment between our safeguarding strategy and our domestic abuse strategy is really, really important. So absolutely welcome the opportunity to refresh that and get that alignment as good as it needs to be.
Martin.
Thank you. I would also like to thank you, Sharon, although I've worked with you for far less time, but it's been great whilst we have worked together, and certainly your interest in doing better work and supporting children around public health. It's very welcome. I think what I would say, particularly around domestic abuse, there's a huge amount of work happening across many services, and certainly we're no different in terms of the work that we do in the Safeguarding Partnership for Children. What I would say, like many services and many of the things that we've heard today, really, we're often investing huge amounts of money in what is a very late intervention. And parental conflict, particularly around children, unresolved conflict, and helping people find different ways of dealing with conflict is the early help approach to domestic abuse, in my view. And there's something more that we need to do around helping people find the tools to deal with unresolved conflict, rather than continue to, in many ways, just put investment in the very end of that issue.
Thank you, Martin. Mabs, did you want to come in?
Yeah, thank you. It's just in relation to a comment that was made about police supporting the data and what comes back to the board. Chair, we'd be more than happy to do that. Clearly, we end up dealing with it in a very reactive way. what gets reported to us. Domestic abuse is a significant issue for us from a policing point of view. It's also a priority as part of our VOG strategy, violence against women and girls, not only for North Yorkshire Police, it's also the Police and Crime Commissioner's priority. We do a lot of work with the Police and Crime Commissioner's office in relation to not only domestic abuse and dealing with the causation factors, but also how do we support victims. And there's a number of victim services commissioned by the Police and Crime Commissioner which support the policing response to domestic abuse. It's a significant impact to children in particular, which we know it is. We have a really good track record as North Yorkshire Police in terms of the amount of domestic abuse, domestic violence protection orders we get, domestic violence protection notices we achieve. We're nationally really high on that, and that's been commented upon. Our breach rate on them orders is really significant. Our repeat rate is really low, which is good. But we also are aware that there's a significant underreporting, in particular in some of our rural communities, in relation to domestic abuse, which we need to do much more collectively on to not only raise awareness, but increase reporting and confidence of both victims and other individuals in the household. Thank you.
Great, thank you. Well, hopefully this is the start of that conversation, which we will take forward. And I'm very happy to agree now that we will absolutely receive the new strategy when it is ready at this board. And it would be great to involve safeguarding some of the voluntary sector partners, as well as the police in that debate and any others that need to be part of that discussion in order to ensure that what we take forward in terms of your recommendations, but also just the wider strategy going forward, is putting the safety of people in the community, whether that's women or their families, or ensuring that we are addressing perpetrators and trying to ensure that, you know, our communities are safer places. That we take forward that with a health-centered approach, which I think is why it was so welcome that report has come from the Public Health Director. And I know that you have, you know, absolutely championed the need for health to be at the heart of what we do as a local authority. I, as the exec member, as your outgoing exec member, well, absolutely, you can rely on me to take that forward. And for us as a local administration, that is one of our absolute priorities, to put health at the heart of what we do. We will also endeavour to try and address some of those very, very challenging and chronic health inequalities across the city, which we know is a huge challenge. But thank you for everything that you've done. Thank you for your report, which we receive. And we wish you the very, very best. And if you spot things that we're doing wrong, please don't hesitate to let us know. Thank you. I think I just needed to receive that report. In which case, I thank you everyone for your time. Look at that, I've managed to catch up. I need to do any urgent business. Do we have any urgent business? No, we do not. I need to sign the minutes, which I probably need to do within the time of the meeting, so I'll do that now. Thank you all for attending. Thank you for your time. Thank you for those who attended online. We'd love to see you in person, not least because if you want to have a proper say, you need to be in the room, because I keep being told that if you're online, you're not really here in a statutory sense. So this is a statutory meeting, so please come in person when you can, but we appreciate you making the effort to be there online if you can't. Thank you all for attending, and our next meeting is in January, I think. Brilliant.